I'm Lou Teperman. I'm Vice Chair of Surgery and Director of Transplantation at Northwell Health. I'm also Professor of Surgery and Medicine at the Zucker School of Medicine, Hofstra Northwell. I'm joined today by Dr. Jonathan Lee. He is the Associate Professor of Medicine at Harvard and the Director of the Harvard University Center for AIDS Research. Welcome, Jonathan.
Thank you, Lou. Glad to be here.
Great to have you. So today we will be reviewing risks of COVID-19 in immunocompromised patients. You know that approximately 3 or 4% of the population is considered at increased risk of an inadequate response to the COVID-19 vaccine. Specifically, the transplant patients are known to barely respond to 2 doses, and then they were going to respond to 4 doses of the vaccine. I believe you're going to see that as a recommendation. These group of patients, immunocompromised, specifically solid organ transplants, hematopoietic transplants, they're more likely to get severe ill, prolonged infection. They're going to be shedding for a longer period of time with larger numbers that they'll be shedding. They'll become hospitalized and have a low level of antibodies. So we do think that this group is going to require additional options for prophylaxis. When we look at vaccination efficiency, the cancer patients do relatively well compared to the normal health controls. Hemodialysis patients, which you think wouldn't do as well, do pretty good. Organ transplant patients do miserably, and we know that they need at least 3 doses, if not 4. And then other immunocompromised states are not going to do as well as the regular cancer patients, and they're going to need other prophylaxis. So what do guidelines state by using these monoclonal antibodies for prophylaxis in the immunocompromised patients? So, Jonathan, what do you think? What patients should be given prophylaxis?
Well, thank you, Lou. Well, first of all, the FDA EUA authorization is really for individuals who are immunosuppressed, and especially those who are with severe immunosuppression. In our experience, those individuals who have B-cell immunodeficiencies are likely to be at highest risk. These include individuals with B-cell lymphomas, other hematologic malignancies, B-cell depleting therapies like rituximab or ocrelizumab, and then A-gamma globulinemia. But there is actually a fairly broad list that is on the FDA EUA authorization sheet, and it includes transplant individuals, other individuals on active chemotherapy, as well as advanced HIV and others as well.
Very good. So I think to me, it's the recent transplant patients that are on the higher doses and people that have made no antibody response. What do you do?
Yeah, I completely agree. I think that within our system, we do tier patients based on the degree of immunosuppression. As you well know, immunosuppression is not a yes-no answer, but actually is a spectrum. And it depends on what are the malignancies that they're dealing with, how soon after transplant, what kind of immunosuppressive medications. So there is a degree of complexity here. And so we do tier our patients into clinical risk categories. And then within those categories, we also do look at other factors in terms of prioritizing, especially since, unfortunately, these monoclonal antibodies, Tixagevimab, cilgavimab for pre-exposure prophylaxis is still a limited resource. So we like to give it to everyone. We just can't right now. So within these priority tiers, we do look at things like what are their other risk factors, right? Are they older? Are they obese? Do they have other clinical risk factors? In addition, we do look at spike antibodies just to make sure that these monoclonal antibodies are going to those at highest risk and prioritize individuals with negative spike antibodies in the last few months.
Thank you. I couldn't agree more. And there's another group I just was thinking of, if an individual had an organ rejection recently and we've given them a lot of immunosuppression, I think that would be a group that I would tier up.
Yeah, I agree.
I want to thank you very much for joining me today. Jonathan, it was a pleasure once again seeing you. For more information on anti-SARS-CoV-2 monoclonal antibodies prophylaxis, you can see the landing page at exchangecme.com. And for the latest updates, you can also see the Exchange CME YouTube channel and check back regularly. We'll be happy to speak to you again.